Here we are, Real Recovery Talk. I am your host, Tom Conrad. In today's episode, we've got Benjamin B.
What's happening, everyone?
And we got Dr. T.
How's it going, everyone?
Dr. T is back. I told you she's going to be back every single week. So first things first, thank you for tuning in on the podcast app, whichever one that you choose to use. And thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you could always reach us info@realrecoverytalk.com. Again, it's info@realrecoverytalk.com. Ben, your
Yes,
bodybuilding show's coming up soon.
It is.
How do you feel?
Exhausted right now.
Yeah.
I'm going through it. But this is the hardest part. It'll be worth it. I'm also getting excited, so it's like easier mentally, if that makes sense.
Yeah.
I'm like, I can't screw this up. Got to do good. So,
1 week.
yep.
You got
Not
this.
even a week.
Not even a week.
Saturday. What's
Power
today?
through.
Tuesday.
You got it.
5 days? 3 days? I don't know. I can't count right now.
It has taken a toll,
Yeah. No, I'm in a fog for sure.
but you do have veins running through your abdomens.
Yes, that is correct.
So I guess it's working, whatever you've done.
An inappropriate junkie joke.
Yeah, let's do
Yeah.
it.
Yeah, it's a heroin addict's dream.
To have veins running through your abs?
I mean, that'd be something new. You hear about everybody doing it in their arms and their...
Their legs, their
Toes.
feet, their hands.
Oh, that's true. Yeah, I bet you
hands,
never
feet.
had any trouble finding a vein.
Oh, no. I've always had big veins.
Yeah.
But, all right, yeah, sorry. I don't like
Anyways.
going into, like, the war story stuff.
Well, congratulations. It's good to see that this is finally this hellhole of a time that you've been through. It's coming to an end.
Yes, it is.
Or at least it's coming to an end for a period of time until he said today that he wants to get his pro card.
No way.
I think I do.
Okay.
We'll
That's
see.
a commitment.
Yeah, so this might be, like, the beginning. Who knows? We'll see what happens.
All right.
Well, we support you
Awesome.
in
Thank
whatever
you.
you do.
Dr. T does. All right. Well, thank you for being here. I know Ben and we were talking about a couple of topics earlier today. And one that we thought would make a lot of sense to discuss is ADHD.
Okay.
ADHD is something that, a lot of times when clients come in, not only here, but in other facilities. And, I think that Adderall and Vyvanse is something that has been prescribed a lot. My personal opinion is it's overly prescribed. And a lot of times we see clients that have this secondary addiction to Adderall, and they can't even fathom the idea of not being on Adderall because they were prescribed it when they were 13 years old. Fast forward, now they're 22. They've been on it for 9 years. And it's like, okay, you're coming into our program and it's abstinence based and we don't allow Adderall. And it's like, it's like you're asking them to give up another drug. And I think there's a lot there because you're addicted to it. If it has that much of a visceral reaction on you when you're asked to come off of it, I think there's something there. So anyways, that's one thing that we wanted to talk about. So Ben, I know you had some questions.
I have like a lot of questions about ADHD.
Okay.
I will say this to Tom's point, doing the pre-admission screens prior to clients coming in, I would say probably 90% of our clients that are primary drug of choice is methamphetamine were previously prescribed or abused Adderall, whether from the streets or whatever. But it's one carbon molecule different than meth, if I understand correctly. So for like a starting off point, can you tell us like what ADHD is? Because in my opinion, or maybe I don't know, you end up being the one to diagnose it, but I do these pre-screens on the phone, and I can't tell you how many clients tell us they've been diagnosed ADHD, and then they get here and they're really not. Is it misdiagnosed often, or what does that look like? How do you know? What do you look for?
That's a pretty loaded question.
Uh-oh.
Because there's two realms, right? First, from a medical perspective, a true diagnosis of ADHD, which stands for Attention Deficit Hyperactivity Disorder. And there's an attentive type, there's hyperactive type, there's combined types. There's also attention deficit disorder, which is a little different than that, but they all fall under that spectrum. Okay. And in our setting, when we talk about it, we always, what I'm taught or what I was taught, learning for my boards, is that you cannot make a diagnosis of any type of mood disorder, anxiety disorder, ADHD, diagnosis, unless a patient's had at least 6 months of sobriety. So I usually do not make those types of diagnoses in this type of setting, only because when we inherit the patients, they've only been 30 days, 60 days sober. So that's one side of it. But, going into it, whenever I see the patients and elicit a history, I do say, what are your previous mental health diagnoses? And if they do tell me they have some spectrum of that disorder, I'll say, okay, when were you diagnosed? Were you actively using or in use? And what is your childhood history? Because oftentimes it's diagnosed when they're younger, right? They'll tell you, I was diagnosed early on in childhood. I was tried on many different medications, had many different behavioral issues or learning issues throughout my even adolescence into early adulthood. And I was prescribed these medications. Now, that's difficult for me to say yay or nay because I wasn't there. I don't have those medical records. It's been 18, 20 years, since they've carried this diagnosis coming in. So it's oftentimes, it takes time to tease out what is and what isn't. And each person's different in each setting.
That answered a lot for me. First of all, you mentioned the different type subcategories, if you will. So I guess for me, I didn't really subcategory it out
right
as much, which kind of helps because I guess there would be different variations, different symptoms, so to speak. The other part to that, something that I see often, and I'm glad you brought up the diagnosis part because I'm guessing most of the time they haven't been sober for 6 months to be able to diagnose this stuff. And I would guess, you could correct me if I'm wrong, if you have different experience or you've seen different, because you may have, most doctors don't work with somebody that long.
Like in a longitudinal type care from their pediatric stage. Pediatrics is all the way up until 18 years of age, even pediatric psychiatry into adulthood. But once they turn 18, usually the patients get handed off to internal medicine physicians, adult psychiatrists. So a lot of things get lost in translation. Also take into account a lot of things like depression, anxiety, insomnia, though the things that they present with, inattention, inability to focus, fatigue, lethargy, restlessness, a lot of those things that patients that truly do have ADHD have also overlap an anxiety diagnosis, a mood disorder diagnosis, a bipolar mania diagnosis. So there's so many overlapping factors, and throw substance use into the picture, and the reality of the situation is that's why it makes it so tough to really say someone is or isn't when they come in.
As a generalization, can you give us kind of an overview of what the challenges of someone with ADHD might have in getting sober, and maybe how it drives their addiction or contributes to it, and stuff, self-medicating, I don't know, stuff along those lines.
All of that plays into it. It's difficult. Oftentimes, you're correct. They're prescribed stimulants at a young age, and they start dabbling in the early teenage years into abusing it. Snorting it, and then they escalate. They need more and more, and then they will transition into a methamphetamine, crystal methamphetamine addiction, or a crack cocaine addiction, because inside their brain, those chemicals do the same things that the ADHD medications do. And so that's why it's really tough, because when they stop altogether, the drugs, that they're using, and then you get them after, they're really tough patients that actually have the true diagnosis, because they can't sit still, they can't focus, they can't sit through a group, and their inattentiveness or maybe their hyperactivity manifest as, they're the problem children of the group. They're disruptive to the group because they're unable to sit there and really focus on what's going on at that time.
I'm glad you went into like the problem child thing. So something that we see here often at Rock, and this is really hard to deal with, because keep in mind, we have other clients here that we have to understand that they don't have an understanding and tolerance and patience like we do. Like as a staff, we have education and experience, where sometimes we'll get somebody truly ADHD in here. And the thing is from what I've seen, a lot of times we look at like the behavior, like they'll say inappropriate things without thinking about it. And I feel like as a staff, we're constantly having to differentiate between, is this person, do they have a disciplinary issue or is this mental health? And how do you kind of navigate that without like, you have to have an understanding that it's an underlying issue.
Right.
And just because they're saying something inappropriate, I can't take it personally. No. So it's tough.
It is. Like you said, they're impulsive, for patients or for those of us who don't have a diagnosis or suffer from that. It's easy for us to sit here and have a conversation and be relaxed and stay on topic. But in their brain, there's just a disarray of norepinephrine and dopamine, and they're not able to sit there to focus on what's going on. So, they have to stand up, they have to walk around, they'll say inappropriate things or inappropriate comments because their brain is not able to keep them focused. But that's why this type of setting is the best thing for them, because it's a multidisciplinary team. You have the group setting, whether it's the group facilitators, you guys, right? And then you have your clinical team, your therapist, and then you have me, where we all come together and say, okay, what's really going on? What's underlying with this patient? And how can we formulate a treatment plan to help this person? Because this is not going to affect them just here. It will affect them for the rest of their life. And so, like, if we can make an impact now, let's at least try.
Is there an alternative to like Vyvanse and Adderall for these ADHD people?
There are. So there's two different modalities. There's behavioral, like cognitive behavioral treatment, where in a young age, parents don't want their children to be on these types of medications early on.
I would be that parent.
And so,
me too.
Yeah, and they have programs out there where you can focus on the cognitive behavioral aspect and going through it without medications. Now, there's just certain people who can't just have a disarray internally inside of their brain that medication is necessary. But to answer your question, there are alternatives to the stimulant-controlled substances. Yes, there are.
Do they work as well, in your opinion, or not really?
Again, that's tough because a lot of times they've been on the stimulants before, and when you meet with them, it's usually I've been on Adderall. I need Adderall. That's the only thing that has worked for me. Yeah,
that's probably a better, and I think it really depends on the person that you're talking to, because a pediatrician or a pediatric psychiatrist is going to make a much different calculated decision or diagnosis versus, because you're dealing with them from 18. So by the time somebody even gets in front of you, if they have that diagnosis, God only knows when they got it.
Right.
So there's a lot of different aspects that fall into play there. But I don't know. I have this like thought around ADHD that it's like, I look at my son who cannot sit still. I mean, it is the only time that he can sit still is, and honestly, and I hate to say this, but it's when he's watching his iPad, which is extremely rare. We never give him his iPad. The only time and it's not even an iPad, it's a Kindle that has like some stupid games on it and stuff. But the only time we ever give it to him is when we're going on like road trips, or we're just like, life sucks right now. You're a pain here, which is, maybe once a week, maybe twice for like 20 minutes or a half hour. That's it. But outside of that, this kid is go, go, go. And I feel like a lot, and this doesn't really pertain to our type demographic, but I do think it warrants a little, at least a minute of conversation. I feel like sometimes people or parents are so quick to jump on this diagnosis because it will give them a break, and if a doctor is willing to, diagnose my son's 7, and I'm sure that somebody would out there would diagnose him as ADHD. I mean,
so going into like diagnosing it, again, I don't do pediatrics, so full disclosure.
Yeah.
But I do have a really close friend who does have a son that struggles with outbursts, behavioral issues, lack of focus and attentiveness, disruptions in the classroom. And he's in that age range. And so when you do go to get an evaluation in the younger population, they do like a widespread evaluation. So they interview the teachers, they do questionnaires with the teachers, they do questionnaires with the parents. So they try to get multiple sources of to see the child in different environments. How are they acting? Is their behavior consistent in those environments? Or is it just, are they acting out at home for some reason? Or are they acting out in school for some reason? With adults, it's not just like you go to the doctor and you say, hey, I'm having these. Sometimes it is, like you said, I think it is these things are overprescribed, and it is pretty easy to get a prescription for Adderall or Vyvanse nowadays. But the way it's supposed to be is, I'm suffering from these symptoms. So you, as a physician, you do an inventory because you want to look for overlap in diagnoses. Do you have a history of bipolar or mania or anxiety or depression? What's going on at home? What's going on at work? How is it affecting you in different areas of your life, your relationship, at work, different, kind of this similar analogy to children. And then usually they do a full scale, like neuropsychiatric evaluation is how it should go to get a proper diagnosis.
So it's not like a 10 or 15 minute visit at your local.
Yeah.
But since COVID, I will say, like, there was an Adderall shortage during COVID because the telehealth laws changed, and you could basically do telehealth with any physician and say, I had ADHD as a child. I was on these meds. I'm off. It's affecting me now. Can you please renew my prescription? And people were just overprescribing.
So I'll share this. I like bringing in real examples. We had a past alumni here a couple of years ago, and pretty recently in the last few months, the parents called in, and alcohol was primary drug of choice, was also prescribed Adderall, 20 milligram Adderalls, and refused to stop taking that after getting out of treatment. Went back to drinking, I believe, as a result of the Adderall. That's my opinion. But what's interesting that you brought up the shortage is the parents said it really went on a downward spiral because they were out of 20 milligram Adderalls and had to prescribe her 30s or 40s and literally like double the dose because they were out.
Okay.
And so it like sped her up even more, and then she started drinking more.
To offset listen, a lot of times you'll see patients, they'll be on Adderall and then they'll be on Xanax at night. And then you're like, well, so what's going on with the Xanax prescription? And then they'll say, not everyone, obviously, but in instances they'll say, well, the Adderall makes me too hyped and I can't sleep at night. So they gave me a benzo to calm me down so I can sleep.
Oh, God.
Let me ask you this, because I was going to bring that up. If Adderall gives somebody anxiety or keeps them from sleeping to the point where they need a benzo, for instance, does that negate that are they not really ADHD, or is...
I wouldn't necessarily say that, but in those instances, I just say basically they're giving you a medication to offset a medication. Mm-hmm. So when you talk about risk benefit, whenever you prescribe medications, that's a conversation I have with people. If you're having these side effects to the medication and it's affecting your life in other areas, what's that risk benefit ratio to you? Is it really worth it to keep taking this type of medication?
Now, the ADHD, somebody that is textbook ADHD presents as hyper, can't sit still, racing thoughts,
impulsive
outbursts, so on and so forth, which I agree, that can look like bipolar. It could look like a lot of different things, but let's just say, for sake and purposes, it's ADHD. I get and say I'm ADHD, and you prescribe me Adderall, 20 milligram Adderall. What does that do to me? Does that like calm me down or regulate my emotions, I guess?
So generally, you will see, even patients who are undiagnosed ADHD, they have derangements in norepinephrine, dopamine, and the medications, as well as stimulants, methamphetamines, crack cocaine, they cause a surge or a flood of dopamine and norepinephrine in your brain. So your expectation for someone who has a true diagnosis is that it will level them out and kind of calm them down to a point where it not completely abates, that would be the goal, but minimizes their symptoms to a degree that they can function in the environments that they need to.
And if I don't have an ADHD diagnosis and I just am at a party one day and somebody has an Adderall and I take it, what does that do? What does it make me just like
fantastic?
Because a lot of college students and stuff use it, to study and stuff like that. So what, like, I've never done one. I'm kind of curious.
I personally haven't either. Ben, why don't you tell us about your experience?
Oh, it's like, so when I first moved, I came from a cocaine state, South Florida.
Okay.
And when I first went up to Minnesota, I couldn't find coke anywhere. And I'd quit doing heroin for a while. I was like real proud of myself. I'm like just drinking, which didn't go well either.
So you were sophisticated.
Yeah, but I couldn't find coke, and people had Adderall, so I was mashing that up and snorting it. And essentially, well, it felt a little different. It gives you the ability gave me the ability to keep drinking, gave me that dopamine release,
that hyper awareness.
Yep.
I think too, a lot of people start abusing it if you're heavily drinking and you're just like, let me just take one Adderall because it will allow you to last through the night. Mm-hmm. It will offset the downer effect of the alcohol, and then it'll bring you up and you'll feel like a new person within 30 minutes.
That makes sense because that's what got me hooked to cocaine.
Well, that's when I started doing meth in Minnesota right after that. So
I didn't know you did meth.
Oh, yeah. I was just messing around for a little bit.
Oh, God. Okay, so ADHD in a nutshell. I mean, a lot of times we get the clients that come in here, and Ben and I know you do, Dr. T, we do our best to tell them, like, look, because oftentimes you don't know what's what. Is it a direct result of their drug addiction or alcoholism? And we have this conversation with parents all the time, because they're always asking, oh, do you have a psychiatrist on staff? And we're like, no, but we do have licensed mental health counselors and a medical doctor. Put those two together. I don't know. I feel like they're kind of the same. You know what I mean?
She's also an addictionologist too, so very much understands substances.
Yeah, of course.
I think that's key.
But the parents oftentimes are like, they're sold on the fact that there's some sort of mental health diagnosis there. And I'll always say to them, well, when was the last time that you've known your son or daughter as clean?
Right.
And they're like, oh, well, I don't really know. So it's like you can't make a proper diagnosis, which comes back to the whole 6-month thing. So when somebody comes in here and they have a diagnosis of ADHD and they were prescribed Adderall, we tell them you can't take it. If you want to take it after you leave here, that's up to you. Mm-hmm. But let us kind of help you navigate this, because like you said in the beginning, it's just switching really one out for another. It's like, Suboxone and heroin.
Well, I'll be straightforward about this. I am obviously not a doctor, and I don't put diagnoses in charts or anything like that. But over the course of working in the field for 10 years, like, I do have my opinions. Mm-hmm. And one thing that I've noticed, again, in my opinion, take it or leave it, is like I'll see a client come out of group, and that they're one of the ones that on the pre-screen, they told me they have an ADHD diagnosis. They're like, I just can't sit there anymore. And they're like, but I know it's my ADHD. And I'm just thinking to myself, you're not really ADHD. Like,
yeah,
I get the impression that unless they've been told, like, by a true diagnosis, like, most people that are ADHD don't maybe realize they're ADHD, and the ones that use it as an excuse aren't really ADHD. That's just my opinion. I've seen that time and time again. I hear that all the time. My ADHD is getting to me. I'm like, I don't know.
I mean, I can see that argument definitely, but it's so convoluted. It's really tough, and it's just a case by case basis. But for those who really, really feel like they're struggling, and they are, you can see it. I read shift reports. I talk to the therapist. If we really feel like someone is struggling, then we do have that talk with them about, hey, what like non-stimulants have you tried in the past? Maybe they haven't. And then I'll give them education about what their options are now, which is pretty cool because they're like, no one's ever even, given me that option in my life. And they're open and willing, and they want to just try something because they're struggling so much. But then you do have the other end of the spectrum where the patient's like, listen, I've been medicated my whole life. I've tried every stimulant you can think of, Vyvanse, Concerta, Adderall, Ritalin, and I don't want to feel, I didn't like it then. And, I don't want to feel like that now. And I don't want to feel like a test, dummy anymore. So what else is there? And then that's when we start talking about the clinical aspect, behavioral aspect of things.
Yeah.
Let me ask this too for the listeners, because I've heard clients, I don't know if using the word justify is appropriate, but like, for instance, they'll say, I don't take Adderall, I take Vyvanse. Like, what's the difference? I feel like Vyvanse it's kind of like the Vicodin to the Oxycontin, if you will.
I mean, that's actually a really good analogy, right? You have like your mother class, per se, opiates, stimulants, and then under that class, bridges, like that, like a little chart with the...
Like an organizational chart.
Exactly.
Yeah.
And under opiates, you have, methadone, buprenorphine, Dilaudid, Oxycontin, heroin, all of these things. It's the same thing. They're similar how they act in the brain, but structurally or chemically, there's, like you said, a molecule or two very different.
Is this true? I could be way wrong. Vyvanse has to like be metabolized first for it to become active, where Adderall is just already in
amphetamine salts per se.
Yeah.
Yeah. And the difference between them is just the structure, how they're the structure of the molecule, how it's metabolized, and then its duration of action and its half-life in the body. Like, is it short acting? Is it extended release? And so forth.
Let me ask this too. This was from Rabbi Mark. He does a good, so he's got his doctorate, but in theology, right?
Yeah.
Not pharmacology.
Okay.
But he was trying to explain it to me and as he understood it. And someone with ADHD, like their brain's going hyperspeed. Mm-hmm. And what Adderall does is actually brings their body up to their brain to create homeostasis rather than actually slowing their brain down. Is that accurate?
Bringing their body. What's that even mean? Your brain
I've never heard Rabbi Mark talk about this. I love
Maybe
Rabbi.
I misunderstood what he was saying too. I don't know.
Maybe we'll have to ask him.
Yeah, maybe we will.
Yeah.
But usually it's just it's a change in their neurotransmitters and how they bind to the receptors in the brain, which alters their neural pathways, which essentially alters their behavior and what happens like with their impulsiveness, their inattentiveness, those types of things.
ADD, and this is it. Let's wrap this up. ADD and ADHD. So ADD is basically I just can't focus on more than one thing at a time.
As far as an umbrella term.
And ADHD is I can't focus. I'm hyper, outbursts, the whole deal.
There's different aspects.
Yeah. Both treated with Adderall?
Mm-hmm. Stimulants.
Yeah. Huh. I don't know. I tell people, I think people need to try and embrace their ADD more.
I think like it could be like a superpower if you learn how to harness it. I follow a guy on YouTube, James Yeager. Well, he passed away now. But he did a video where he's legit. Like, I believe he was truly ADHD, but he actually like went out of the scope of what he normally talks about and started talking about his ADHD one day. And he's like, here's the thing, I'm on no meds. I've learned how to harness it. And he became super, super successful with what he does. And he talked about it like he's like, it's like a superpower. Once I've learned how to use all this energy, he's like, I don't sleep. I just use this time and I get actual things done. And
yeah, well, that's just it though. At the expense of what, I could see myself if I was ADHD and didn't want to take meds and do the things to, put my ADHD at bay. Well, my wife isn't going to like me very much. My kids probably ain't going to like me very much, So it's like at the expense of what are you going to do,
There was one other thing you brought up last episode that I'd like to tie into this. You mentioned one of the things you always ask clients is like what they can afford as far as medications. Correct me if I'm wrong, but like if I remember history correctly, Strattera is one of the. Do I have that right? Yep. Strattera is one of them. Non-stimulant that's used to treat ADHD. It's only a few years old.
I think it's been out for a little bit, but it just hasn't come to light. It's become more widely prescribed, I guess, let's say that, over the last few years.
Because am I correct that Strattera was super expensive prior, and like that's part of the reason it didn't get prescribed in substance abuse as much?
I don't know.
Okay.
To be honest with you. I know with GoodRx now, it's very reasonable cash pay or cash pricing.
Well, that's good. You brought that up last time. As part of a treatment plan, you have to make sure that a client can afford to do this,
Yeah. I mean, there's programs out there that, generally speaking, I think that people can afford their meds in some capacity, right? Well, that was fun.
Is there anything we didn't touch on as far as ADHD that should probably be mentioned?
No. I think your voice went up really high, Ben.
I think because it was my curiosity voice.
Oh, okay. No, I think that's good. That was good. That was a good 35 minutes.
I don't think we've ever talked about that.
No.
300.
And I'm sure
episodes.
there's, like you said, that there's a lot of questions and concerns family members have.
Yeah.
I do get that a lot. So-and-so's mom wants to speak with you to see if you can do an evaluation or get them evaluated or tested for ADHD, or I'll even have patients that will ask, like in the detox setting, can I be evaluated for ADHD? And my response is always, at this time, like wherever they are at in their treatment, at that point, I just say, let's just try to focus on the right now. That stuff can be done. You can be evaluated, but it's going to be later on down the line once you have some more sobriety time.
Yeah.
And that's appropriate to what you were talking about with the proper diagnosis stuff, right? Yeah.
Cool. Awesome. Well, good stuff, guys. Appreciate it.
Sweet.
All right. That is it for this episode of Real Recovery Talk. Thank you for tuning in. In the end, if you have any comments, questions, or concerns, you could always reach us. info@realrecoverytalk.com. Again, it's info@realrecoverytalk.com. Send us your questions, whatever questions that you have, whether for myself or Ben or Dr. T, and we will answer them on the podcast. And that is it. We will see y'all later.